are very pleased to have the opportunity to bring to you Dr. Thomas Campbell today. He's a physician, a researcher, an educator, author, and co-author. And yes, you read that right on the opening slide. He is the co-author of the China study with Dr. Colin Campbell. You know, that book that when we talk to people about their journey, they say, and then I read the China study and it changed my life. And it changed my life too. I'm one of those. Well, since then, Dr. Campbell has gone on to make medicine his field of study. And he's a physician practicing at the University of Rochester Highland Hospital. He's the founder and co-director of the Nutrition and Medicine Research Center. Early as an educator, he directed the Campbell Center for Nutrition Studies, and he wrote a manual for the certification program while he was there. And today, as a researcher, he will be sharing with us his passion for scientific knowledge and finding the truth, the very definition of scientific research, so much like his father, who taught us that that's what science and research is about. And he works with individuals and groups to prevent and treat chronic diseases using diet and lifestyle. Welcome, Dr. Campbell.
Sure, my pleasure.
Okay, so we've had the Campbells in our history of Chat and Chew More Plants for quite a while. One of our early Skype speakers was Dr. Colin Campbell, and he was coming to us from, I think it was North Carolina, when your sister Leanne had that cooking summit.
Oh, yeah.
And then Leanne came to Polk County as well. And she was telling us when she was here, it was so cute. She was telling us all about the process of being a college student and dealing with the specimens that came from the China study and helping her dad. But you didn't do that, evidently. You helped write the book. Is that correct?
I did, yeah. The project itself and the research was my dad and many collaborators. And after that was done, years after that was done, and he had published and written some of his seminal research, you know, he wanted to write a book for the public, encapsulating his journey and a lot of other nutrition information. And so I helped him write that book for the public. So it was trying to study the book that I was obviously very, very much involved in, but not the research itself.
Well, did it change your life too?
It did, yeah. I was, believe it or not, I was actually pursuing theater and acting before I wrote a book with. I started writing the book with my dad. I enjoyed writing and communicating, and you know, I thought that was going to be a brief project, and I'd go back to my previous life. And it ended up taking years more than we thought it would, and set me on a path to go to medical school and become a doctor, and everything that I've done since. So yeah, it was a profoundly influential thing.
Well, you've done a lot of research too. I visited the University of Rochester's webpage, and just on that page you had 19 published journal articles. So we're excited for you to share with us today. Tell us about the two that are recent, the one on diabetes, and then maybe you could do the one on cancer. So what were you studying with diabetes?
Yeah, well, in my practice, working with individuals, I have had a lot of success, and I think most people who practice lifestyle medicine will tell you this. I've had a lot of success with people who, people who have insulin-treated type 2 diabetes. So they have type 2 diabetes, and they require daily insulin, and they change if they're motivated, you know, the rare person who's deeply motivated and will change their diet drastically very quickly, I've observed that their insulin requirements go down a lot. I mean, they need a lot less insulin quite quickly. And so if you look at the literature, though, although there's a lot of diet and diabetes literature, there's actually not that much with regard to treating advanced type 2 diabetes, insulin dependent type 2 diabetes, so people who insulin treated type 2 diabetes. And it's a little niche, that is relatively under researched. And part of the reason is because these folks oftentimes have very advanced type 2 diabetes. They've often been excluded from nutrition research because as diabetes progresses, it's probably a little less amenable to dietary effects. It's probably a little more resistant to dietary benefits. And secondly, this is just my guess, secondly, these people who are on insulin, particularly a lot of insulin, if you go messing around with their diet dramatically, you run the risk of, changing their blood sugar so much that it becomes kind of a risky medical proposition in terms of research. So you got to have very tight, control and observation with these folks. So they haven't been studied very much when it comes to using food as medicine. So what we did in our diabetes studies, it was a small little sort of introductory type of study. We took 15 people who had insulin treated type 2 diabetes. And these were folks who had, quite advanced type 2 diabetes. So on average on their insulin, they were taking on average about 90 units of insulin a day. To give you a sense of what that means, we might start someone on insulin by the time their diabetes progresses where they require daily insulin shots. We might start someone on 10 or 15 units of insulin a day. And these folks on average were on 90. There were people on over 200 units of insulin. They had diabetes diagnosed for about 12 years on average, which is longer than most nutrition intervention studies. And what we did with them is we put a continuous glucose monitor on them. So we were checking their sugar every 15 minutes. We had them do all sorts of diaries and record how much insulin they required in every day and what their blood sugar was and their dietary intake and so forth. And we observed them for a week just on their normal diet, their baseline diet. And then what we did is we switched them over to, overnight to what's called a DASH diet. And many people who are listening are probably familiar with, have heard of this diet before. It's what I would call sort of a healthier American diet. Nothing's off the menu, but it's more plant-based. It's much more emphasis on fruits and vegetables, whole grains. There's a little less fat, less salt, less red meat, less processed meat. There's more low-fat dairy. There's some low-fat meat, but generally higher fiber, low, more whole grains. Like I said, fruits and vegetables. So a healthier American diet. So they did that for a week. We measured everything the same way. And then we did switch them over after that week to a week of whole food plant-based diet. And this is sort of the very strict interpretation. It's vegan diet, no animal products, no added fats, no added oils, let me say. So we did allow nuts and nut butters, but there are no added oils in any foods. And we did that for a week, and then we had one more week where we put them on a more moderate sort of more moderate DASH diet for the last week. So they kind of did a modest change, then a bigger change, and then back to the modest change. So sort of deeper into the change over those weeks, and we recorded a whole bunch of stuff. And the main outcome that we were interested in is, if you change your diet so dramatically, and by the way, we actually gave people meals and fed people meals. They could eat as much as they wanted. So we gave them education. They said, okay, if you want to be on a DASH diet and go get a meal, you can buy these things and make your own meal. Here's some recipe, here's some shopping ideas, etc. If you want to do a whole food plant-based meal, go buy these things and do this. But to make it really easy, so they could eat as much as they wanted, but to make it really, really easy so that they were compliant with the diets and we could test these diets as they were intended, we did give them about 1,800 calories a day of meals and snacks just to make it easy. So they weren't limited to those. They could have more food if they wanted, but it did make it easy for them to make big changes in their diet. And what we found was quite remarkable. And I do have a slide here. Our primary outcome, the main thing we wanted to describe was how does actually, I'll show a couple things here. How do insulin requirements change? So these people who are on large doses of insulin and they change their diet, what happens? So the DASH diet, like I said, breakfast would be like steel cut oatmeal, fruit, walnuts, flax. Lunch, turkey sandwich on whole wheat with lettuce, tomato, onion, mustard, mayo, and a salad. Dinner would be fish and a farro salad with veggies, and snacks of some low-fat dairy stuff, nuts, whole wheat, crackers, that type of thing. If you've talked to people eating a standard American diet, this is a much, much healthier diet. And it's what I actually would call a more plant-based diet, right? There's a lot more vegetables, fruits and vegetables here. So this is a modestly plant-based diet, a more plant-based diet. And then when we did the whole food plant-based, you can see it was, vegan. All of this was made with no added oils or butters, solid fats or liquid fats. And so, blend banana flax muffins, fruit, sweet potato enchiladas, salad, bean soup, salad, snacks of whole grain crackers, hummus, fruit, made in our kitchen, a research kitchen. So about 1,800 calories, providing that like I said, they could eat more. And if you look at the nutrient content of these diets that we tested, the DASH diet, so what you're looking at here is the amount of fat, protein, and carbohydrates in these diets. And at baseline, these people were eating, this is the first bar. This is a little small, this labeling, but this first bar is what people were eating at baseline in terms of fat. And then on the DASH diet, it is a lower fat diet, as I mentioned. So fat intake went down. Whole food plant-based, the fat was much lower. And then on DASH, of course, it went back to the DASH amount. The protein intake actually went up on the DASH diet a little bit, non-significantly, in that because it had a lot more dairy, and low-fat dairy, of course, is high in protein. Whole food plant-based, the protein intake went down, and then you can see in carbohydrates, this is kind of where we get some raised eyebrows, because most people who are worried about blood sugar and diabetes, most people immediately think, oh, carbohydrates, that's what I got to think about and focus on. And what we did is on the DASH diet, their carbohydrate intake stayed about the same in terms of total amount. And the plant-based, their carbohydrate intake, we really jacked it up.
I want to ask, how did you convince those diabetics that it was okay to eat all that carbohydrate?
Well, we got some raised eyebrows and shaking heads and like, well, okay, all right, but they'll do it for a week. But they had enough interest and trust to sort of try it out. Clearly even though it was more carbohydrates, it was healthier carbohydrates, right? So it was the carbohydrate quality. Not only was it more carbohydrates, but there's a huge difference in the carbohydrate quality, right? People weren't eating pizza with a whole, white bread and oil crust. They were eating, apples and steel cut oatmeal and whole grain muffins. I mean, totally different. So people, I think, were accepting of that because it was clearly a higher quality carbohydrate. And what we found is sort of our main finding here is that this is what you're looking at here is the amount of insulin people required during each phase of the study, the relative amount. And the red line is the group average. And each light gray line is an individual. So at baseline, their average insulin dose was at 1. That's a relative unit of 1. At the DASH diet, this healthier American diet, lower fat, higher fiber, their insulin requirements immediately went down. And by the end of 7 days, their insulin requirements were full 24% lower than they were on their baseline diet. And I should mention, while we were dropping their insulin, we were contacting people, by the way, every single day to help me or an endocrinology collaborator to help them change their insulin in a safe and effective way, because we didn't want them to be bottoming out their blood sugar as they were changing their diet. So they were contacted every single day, and their blood sugar was all dropping. And as it was dropping, they had to drop their insulin dose. So what you're seeing here is as their blood sugar was 25% lower throughout this time period, their insulin was 24% lower. And then they went on the stricter diet of whole food plant-based. And by the end of that, their insulin requirement was down 39% after just 14 days, with average blood sugars being down 20 to 25% lower. So their blood sugars were much better controlled on much less insulin after 14 days. And then they went back on a more modest diet, with a more liberal diet, and things started getting a little bit worse, although it still was far, far better than baseline. But if people started when they reintroduced, some of the oils, some of the meats, some of the a little bit more processed foods, they had a regression in some of their benefits. So, the main takeaway I think from this, and there's a lot of other findings, but the main takeaway was that after 14 days of these plant-based diets, one a modestly plant-based diet, then transitioning to a strict plant-based diet, after just 14 days, people were taking 39% less insulin, and their blood sugar was down 20 to 25%. And then very quickly, I'll show you, there are a bunch of other markers were improving at the same time. This is LDL cholesterol, for example, which is really important for people with diabetes, because the number one killer of people with diabetes is not diabetes, it's heart disease. And diabetes is a great promoter of heart disease. So when we see LDL cholesterol after 2 weeks, this is a relative change here. After 2 weeks, their LDL cholesterol was down over 30% on average. And then it's the same picture you see, modestly better on a modest plant-based diet, the best under the strictest diet, and then it regresses a bit. And then over here, I'll show you the CRP. This is a marker of inflammation. So we hear a lot about inflammation and how it's chronic inflammation is a bad thing, and it's related to a lot of different diseases. And after 2 weeks, inflammation was down over 40% by this marker. Inflammation was down over 40%. So we had a medicine here. We had an intervention that after 2 weeks, of a modest diet and then a stricter diet, after 2 weeks, we saw insulin down almost 40%, blood sugar down 20 to 25% on 40% less insulin. We saw LDL cholesterol down over 30% and inflammation down over 40%. And now, the takeaway from this, I think, is just describing these are huge, huge numbers, and they happen very quickly, and they happen in a very difficult population. As I initially described, these patients are oftentimes excluded because as diabetes progresses, it gets harder and harder. Type 2 diabetes, and so, as the years go by, actually starts to look a little bit more and more like type 1 diabetes over time. The pancreas continues to burn out over time. So these people tend to be a little, can you really help someone this far along in diabetes, and how much can you help them? And our research shows these huge changes, huge improvements that happen very, very quickly. Now, of course, this study is small, very small and very short. So there are really important questions that remain, which is, what happens after 2 months, 3 months, 4 months, 6 months, a year, right? That's where the real impact you would hope would see. And so we want to do that research. That would be sort of the next study. And we're seeking funding for that now. But that's the sort of next research, because the possibility here is enormous, right? We hear a lot about the GLP-1 agonists. These are the Ozempics, the Mounjaro, and I'm not against pharmaceutical medication. I'm a doctor. I've been trained. I prescribe these things. I'm not against them, but the idea that we have a medication that we spend over $1,000 a month on to do this, and we have here evidence that food is actually much more effective, and people were eating as much as they wanted to be full. They had, I don't care what drug you're looking at, there's no drug on the market that has results like this. There's nobody on insulin treated type 2 diabetes. You can give them a new prescription and they drop their insulin by 40%, and their blood sugar goes down 23%, and their LDL, their cardiac risk factors, inflammation drop, 20, 30, 40% in a couple of weeks. There's nothing that comes remotely close, right? Nothing. So we have these new medications that are costing over $1,000 a month, and these are medications that we really expect people to be on for the rest of their lives. That because if you stop taking them, the benefit goes away, like all chronic disease medications. So these are medications that are enormously expensive, and the implications here are really profound. You could pay for a private chef service to make meals for everybody with insulin treated type 2 diabetes, and it would be cheaper than the prescription medication, right? And if these benefits, if these results were something that persisted and could be maintained, which is the real crux, the real thing to be studied, it's pretty profound implications. Diabetes is, writing these grant applications and stuff and looking at this, you always hear the headlines of diabetes being expensive, but my goodness, when you look at the actual data, I mean, more than 50% of Americans now have diabetes or pre-diabetes, and 1 out of 5 hospital days that America spent. If you look at all the hospital days in America, 1 out of 5 is directly due to diabetes, and it's just enormous. The cost, it's just profoundly huge cost on the society, on individuals, and so yeah, this is our diabetes study. It's just, like I said, a small little study, provocative findings, provocative results that should open the door hopefully for more research.
Yeah, and I was so interested in how with the DASH diet first, they have that nice drop in pretty much everything, and then even more with Whole Foods, and then they go back to a healthy American diet, and it's kind of like, well, so if you have a problem that's chronic and it's bad, you have to really make big changes, don't you?
Yeah, with diabetes, this is probably not true with all conditions, but with diabetes, it appears that, small changes do result in small benefits. So you can make modest changes and actually have some benefit, which is good, is hopeful, because not everybody wants to drop everything and change their diet 100%, right?
Wow.
So intermediate changes actually result in intermediate benefit. But if you really want to have the most effective sort of sledgehammer benefit, then it would be, changing your diet the most, which, it's kind of common sense. The more you change, the more benefit you have. And so our research supports that. And it was interesting because it was across all outcomes. We saw that same shape: modest change, modest benefit; bigger change, bigger benefit. And then when you go back, when you start sliding, behaviorally, this is how I would describe our study. But if someone is eating a stricter diet and they start sliding and they start introducing some more unhealthy food, then you can expect the benefits to slide. And that's, of course, exactly what we saw. So but with diabetes, then it clearly there's a nice gradation, I think, in terms of its relationship to diet.
Yeah. Well, and you're giving hope to a group that there really isn't any hope. They haven't had any positive news like that ever. So now you've taken another group though, and that's women with stage 4 breast cancer. Now tell us about that one.
Yeah, so there's a lot of background research, and everybody who's not everybody, but many people on this call, if you're plant-based enthusiasts or you've taken courses or learned about it, you've probably heard some of the background research that. And my dad was did diet and cancer research and experimental models. There's a lot of observational research, and anyway, that to make a long story short, a lot of this background research suggests that diet may be pretty profoundly influential for breast cancer risks. And the problem is that there's not a lot of human clinical trials in this. You think that with all this background research, I mean, there's been discussion of diet. And if you read my book, my dad's book, The Future of Nutrition, which is an excellent book, you'll hear some of this history where people were proposing were observing and noticing that, diet may affect breast cancer hundreds of years ago. And, that this was a question worth looking at. But if you look at the research literature, again, there's not enough to look, to see if you actually take a group of women and change their diet, how does it affect breast cancer risk? So we want to go down that road in terms of a line of research studies. And our first step was to do what's called a pilot trial, feasibility small study. And what we chose to do was look at women with metastatic breast cancer. This is stage 4 breast cancer, considered, of course, terminal disease. And these women oftentimes have more complex symptom burdens, more complex medications and medical situations and so forth. So, this hasn't been done before with a whole food plant-based diet. So we really needed, and we certainly hadn't done research like this before ourselves with any collaborators. So we really needed a small study to see, could we do this? Could we recruit women? Would they change their diet? Were there any untoward effects, in these situations? Would they stick with it? How would they feel about it? And what were the preliminary changes? So you have to get answers to these very, very basic questions before you embark on a larger definitive study. So we did a pilot project, and what we did is we got 30 women with stage 4 breast cancer. They were on a variety of breast cancer medications and treatment regimens, but we only included women who were on stable treatment regimens, so their disease had reached a stability sort of plateau, so that we weren't having other changing variables as we were doing the dietary work. And we did a randomized controlled trial. So we had these 30 women, and we did whole food plant-based dietary intervention for 20 of them, and for 10 of them they got a control just basically continue as you are. And we did a whole food plant-based diet, and again, it was similar to what I just showed with the diabetes. They could eat as much as they wanted whenever they wanted. It was totally vegan, no animal foods, and we asked no added fats, solid or liquid, no oils. They could certainly have nuts and nut butter, natural nut butters. We did not want them to, there are some women, for example, who already were kind of thin, and we wanted them to go ahead and have calorie dense foods if they, didn't want to lose too much weight. So it wasn't necessarily super low fat, but it was vegan, no added pure fats. And we looked at feasibility stuff. Like I said, could we recruit? Would they stick with it? Did they like it? Were there side effects? And then the preliminary changes in biologic markers and outcomes. One of the reasons we decided to look at metastatic population is that, population with metastatic cancer oftentimes has active tumor activity that you can track and measure over time. So, that would be the standard, case for someone with metastatic disease. So you have someone who has, active tumor, so you can do blood tests and track the cancer activity. Someone with early stage breast cancer, early stage cancer, we don't have the technology or testing to be able to track tumor activity very well. So, once an early stage, for example, once it's treated and gone, we can't see anything more. Even if there's 3 cells somewhere else, we can't pick them up. We don't have that ability. So metastatic gives us the population to an opportunity to track cancer over a shorter period of time, ultimately. So ultimately, that's what we want to do. But again, we provided them with prepared meals. It was not calorie controlled. Some women got tired of prepared meals. They started making their own food. We gave them shopping lists and recipe resources and all sorts of stuff, so they could do it on their own if they felt up to it and wanted to do it, or they could eat our meals. We just wanted to make it easy for them to change their diet in a big way. And these were the typical kinds of menu items that they got.
So the menu items that they can make on their own, they still fit in that whole food plant-based category.
Correct. Yeah, we gave them pretty extensive education. We met with every participant every single week for an hour, and the first meeting was like 2 hours to go through food guides and
Mhm.
shopping lists and recipes and so forth. So they got pretty extensive education. Now, of course, people being people, there's not 100% compliance, but we wanted to give every resource we possibly could to to follow this vegan, no added pure fats. And the feasibility stuff, like I said, the first order of business was just seeing whether we could do it. And I have to say, it went very, very well. We, as we started the study, we decided that if a woman consumed more than 80% of her calories sort of on plan, and we looked at food diaries very carefully. So we did three 20 unannounced 24-hour food recalls. We did a 3-day food diary at the end. If more than 80% of their calorie intake was from foods that were on plan, we considered them to be compliant with the diet. So 95% of intervention subjects were compliant. And in fact, if you look at some, about 95% of all the recorded calorie intake was on plan. And this is looked at quite strictly. If they had a muffin that had some added oil, all the calories from the muffin were off plan. So it was looked at really quite strictly. And it really very, very, very strong compliance. They all completed their testing visits. There were minimal adverse events. There were just a few times where blood pressure was dropped a little bit low, and participants had to have some medication adjustments. That was sort of the adverse event. And as a consequence of this, we found that the dietary intake changed quite a lot. You can see that women actually ate more food. Their dietary intake went up by about 16%. This is solids and liquids actually, but it went up about 16%. Their energy intake went down quite a lot. So you've probably heard, and many people in this group, if you're interested in weight maintenance or weight loss, or that's a common goal, calorie density is really critical. And so this whole food plant-based diets are lower in calorie density. So you can eat more food, but still consume fewer calories. And that's what we found. We were constantly telling women, go ahead and make sure you're full. If you're hungry, have a snack. This isn't a diet. Go ahead and have more food. You probably need a bigger meal. You probably need bigger meals. So this is a very common discussion we had. And women would say, you're giving us too much food. I can't finish all this food. I'm full. I'm very full. But then when we looked at the data after the fact, they really dropped their energy intake quite a bit, by about 26%. Their fat intake went way down. Like I said, we still had nuts and nut butters, and some women probably had a little bit more higher fat diet. But on average, fat intake was way down. Carbohydrate intake went up. Protein intake went down a little bit. And dietary fiber, shot through the roof, a huge change overnight. And just to give you a sense, these are huge changes. And one of the things there, in diet and cancer research is that there have been some large, and this is a busy slide, but I'll show you. There have been some large diet and cancer research studies that have been done. People may have heard of the Women's Health Intervention, WHI.
Uh-huh.
There's a couple large, and this is the Women's Healthy Eating and Living trial, and Women's Intervention Nutrition. I forget what the WINS actually stands for. Anyway, it's these all relate to breast cancer trials, breast cancer prevention in the case of Women's Health Initiative, and breast cancer treatment in the case of the other two. And what this is showing is that in our trial, this is the top bar here. So calorie intake went down significantly more than other trials. Carbohydrate intake a bit of a wash. Protein intake went down. Fat went down farther, and fiber intake went way up compared to other trials. So we really had a total dietary shift. And this doesn't encapsulate all the changes, of course, but totally dietary shift and a very big dietary intake changes compared to a lot of other research, which was our goal. So it was feasible, though. We found women stuck with it. And impressively, when we asked women, you know, if you were talking to someone who was in your shoes, basically, if you talk to someone with this diagnosis who was able and willing to participate in an intervention like this, how strongly would you recommend that other cancer patients be given this type of nutrition and support intervention if they were able and willing? And
Wow.
the average response was 9.5 out of highly recommended. So almost uniformly, very well liked. And we asked them, you know, do you feel that your health has benefited? And 19 of 19 respondents said yes. So they really felt quite good about what they were doing. And their part of the reason for that was that as women were making these huge dietary changes, you know, you think, oh God, you know, there's going to be, yeah, you're going to be eat healthier diet, but you're going to feel worse. Your quality of life, you know, things are going to get, it's going to be miserable. But we did a bunch of quality of life surveys. And what we found was that the quality of life actually significantly improved in the intervention group. Here's some common sort of validated surveys that are used in these types of clinical trials. And the light blue bar is the intervention group, and this is the control group in the dark bar. And you can see the improvements in the quality of life were marked in the intervention group. And this dotted line here that you're looking at on this is what's considered sort of a minimal, what you would this on these graph, you know, on these scales, you get a change in number, but you don't really know what that means. What's a change in number here? So what this dotted line is shows you is that this is above what's considered a minimally clinically significant difference. So if it's above here, it actually means that there's a clinical improvement, like people feel a meaningful difference in their quality of life. And the total quality of life improved, a sub-index related to breast cancer symptoms improved, physical well-being improved, emotional well-being improved. And most markedly, actually, was cognitive function. We found that perceived cognitive function, these women were actually thinking, felt like they were thinking clearly, more clearly, better attention, better focus. So their cognitive function was really quite a strong response in terms of total perceived cognitive function. And this was across, we did about 5 different surveys. Across every survey, across every measure, we saw cognitive function improve. In some measures, we found fatigue improve, you know, fatigue severity, overall fatigue in some of these measures. So we saw energy improve, perceived. So really important, you know, if you think about goals of cancer care, obviously women, anybody with diagnosed with cancer, you want a treatment that's going to hopefully decrease progression, decrease mortality. But you want to choose these treatments. It's always in the context of like, I want to continue living my normal life as much as possible. That's a core part of the goals of care. So we actually found that this very important goal, which is quality of life, maintain quality of life, actually improved as women changed their diet.
And that's so profound when you compare it to the treatments they get that do the opposite. It just destroys.
Right. Well, that's why it's such an important goal, because we ask people with cancer to take such affecting you know, medications that could change your life, and people kind of do this cost benefit analysis, like, okay, it's going to give me 4 more months, but if it kind of ruins my month, you know, my quality of life. So quality of life is really a core part of that treatment picture when someone's diagnosed and treated for cancer. And we found these very promising findings. Now, this is a small study with important limitations. I mean, we were giving women prepared meals, and we were meeting them and giving them a bunch of attention. So was this that we were making their lives interesting or sort of meaningful from the visits, or easier from the food? You know, these are important limitations of our little trial, but this is incredibly hopeful that, you know, people think, you're going to eat all that healthy food, but you're going to, you know, how are you going to feel? And it's like, well, wait, you're gonna feel better, which is kind of takes away some of that sting, that people have about changing their diet, right?
Yeah.
So importantly, we also looked at blood markers. We also looked at, biological changes. And one of the most impressive things, remember I told you they ate more food but consumed fewer calories. We found that women were losing weight. And you might say with metastatic breast cancer, well, that's a little concerning, losing weight and advanced cancer. Sometimes you raise your eyebrows. But people have to kind of realize that in breast cancer, um, it's a fairly unusual cancer where the majority of women during treatment for breast cancer actually gain weight. They gain weight. So weight gain is actually a very common problem with breast cancer treatment, all the way up through more advanced stages. In fact, if you look at women with breast cancer, even stage 4 metastatic breast cancer, their incidence and rate of obesity is just as high or even a little higher than the general population, despite having very advanced cancer.
Well, now you're a certified mate of the American Board of Obesity Medicine. So I'm asking you this as with your background in obesity, is that good to be overweight when you have cancer?
In breast cancer, no. There's a lot of research on this. It's kind of a niche little question, and we know for postmenopausal breast cancer, if you have excess weight, you're at higher risk of getting the cancer. If you look at all women who, at the time of diagnosis, like if a woman comes in and says you have breast cancer, women who carry extra weight have worse outcomes, especially at the highest ranges of that excess weight. And then excess weight gain in some studies results in worse outcomes, so lower quality of life, higher risk of treatment failure, and higher mortality risks. So this excess weight that people have before their cancer, and then they gain more during their treatment. In the case of breast cancer, like I said, breast cancer, this doesn't apply to all cancers, but in case of breast cancer, this is really not a good thing. And women, of course, they're very well aware of some of this information, and they're very well aware of gaining weight during this treatment. So you have a population that's pretty darn motivated. And we found, that in our population, they were, for example, this was a population that was starting right at the borderline of obesity. So BMI of just about 30, which is the border between overweight and obesity. And we found that they lost 1 to 2 pounds a week. Now, that's actually pretty consistent with all of our other interventions. So this was not excessive weight loss. This is like a healthy rate of weight loss, people eating as much as they wanted to be full, 1 to 2 pounds a week, which is typical of sort of intentional weight loss. So it was actually ended up, despite this is a setting of metastatic cancer, this is a very, very hopeful thing that pleased a lot of participants. As they lost weight, we found a whole bunch of other things got better. We found their, typical metabolic stuff like their cholesterol got better. But we also found their insulin dropped. This is insulin resistance. This is like how well their insulin was working. Let's say we found the same thing in the diabetes study that improved a lot. So their insulin resistance, their body's blocking of insulin, sort of decreased by 39%. IGF-1 is a hormone that makes things grow. IGF-1 is wonderful if you're a kid trying to grow bone and muscle. It does its job. But if you've got a bunch of cancer cells floating around in your body, it's not so hot. It's linked to higher risks with breast cancer, prostate cancer, colorectal cancer. So IGF-1 went down within our intervention group. And we found changes in hormones. So we know sex hormones are related to cancer risks. And we found that the carrier protein that carries around our hormones actually increased, which is a good thing because it kind of controls your hormones in your bloodstream. And what we saw in the case of testosterone, as the carrier protein increased, the free unbound testosterone decreased. So that makes your body more able to utilize, theoretically, hypothetically, more able to utilize in a reasonable way your sex hormones. There's less of them kind of floating around willy-nilly to hit inappropriate receptors and so forth in cancer. So this was all very, very hopeful and promising. And then we did some secondary analysis where we had an extra tube of blood. We did a whole bunch of other tests, and we found, boy, we got some really interesting results there. We found a whole bunch of outcomes related to different systems were changing within our intervention group. I'll remind people, this was an intervention group of 20 women. So if anybody here is familiar with statistics, you know that it's very hard to get something that's statistically significant with a group of 20 women. You need a big change to demonstrate something that's statistically significant. When I say it's statistically significant, that means it's not due to chance. It's a change that's real. It's not something that we just observe by chance. And you'll see these are many, many significant findings. Their hormones were changing. I just mentioned the growth hormone IGF-1. I mentioned insulin. I mentioned their sex hormone system, sex hormone binding globulin. Leptin is another hormone related to excess weight. That change, we know leptin, interestingly, a lot of research showing that's actually related to cancer risk and cancer progression. A lot of other metabolism things changed. I mentioned glucose, cholesterol, insulin resistance, immunity, and I'll come back to the glutamic acid in a second. Immunity, these are all different immune system factors. So TNF alpha, these are like cytokines, and they're signaling molecules that our body makes when we have high inflammation. And we know, for example, that high TNF alpha is something that's, if someone has high TNF alpha, they have higher risk of death, higher with breast cancer, higher risk of progression, metastasis, death. And we found TNF alpha came down in these women. These other markers came down. This is a marker associated with apoptosis. This is cell death. Cancer cell death, which is what you want. We found this marker improved. Angiogenesis, these are all markers related to blood vessel growth. And one of the hallmarks of cancer is that it has to have a blood vessel supply, blood vessels that go into the cancer and supply it with nutrients. And that's a result of something called angiogenesis, a growth of blood vessels into the cancer. And it's oftentimes inappropriately elevated. So if you have higher blood vessel growth, you have higher progression, higher metastasis, higher death. We found that all of these markers related to angiogenesis decreased, some of them significant, some not. But these are very, very impressive numbers for such a small group. You know, we looked at many different things and we were just finding like, oh my God, this system changed. Oh my gosh, this system changed, this system changed. And, you know, what we had here to sort of sum up was that this was a dietary intervention where we changed a whole bunch of stuff in a big way. We changed calorie intake, fiber intake, fat intake, fatty acid intake, protein intake, isoflavones, antioxidant. And what we found is all these markers here changed in our little study with small, short little study. We found huge changes in a lot of these things, significant enough to be statistically significant. And all of these markers then represent all of these systems. They represent inflammation. They represent cell death. They represent how blood vessels grow in cancer. They recommend sex hormones. And all of these things are related. And we know that all of these things then go on to affect things like risk of metastasis, tumor cell proliferation, and death, your risk of death. So this was, we just had so many findings that were hopeful. Now, our study was only 8 weeks. So 8 weeks is, even in metastatic cancer, 8 weeks is not long enough to really assess cancer progression. Simply not. We don't have the tools that are effective enough to really assess cancer progression in a population like this. And so what we looked at cancer markers, and it was hopeful. We found that the intervention group had a lower rise, or adjusted compared to the control group. The intervention group had a lower rise in cancer markers compared to the control group, but absolutely not statistically significant. I mean, these markers for any one individual, there's a huge variability. There's a huge range. Our numbers were too small. So this could be chance, is what I'm saying. This could be chance, but certainly they were going in the right direction. These are cancer markers that we use to track cancer activity. So they were in the right direction. So very hopeful little study. And again, like the diabetes study, to really do something here that is hopeful, meaningful for people. We have to do the next study, which is a larger study to actually look at cancer outcomes. Because right now this is a bit hypothetical, right? It's all very promising and hopeful, but it's hypothetical until you can actually see if it affects cancer progression-free survival, cancer mortality, that type of thing. So that next study has to happen.
Yeah, and you sounded like your father when you said, we looked at this and it was affecting this and it was affecting this and it was affecting, remember when he talked about that?
Yes, in his animal research, they looked at a whole variety of mechanisms. Every time they wanted to look at a specific mechanism as to how protein intake was changing cancer, they found many different mechanisms. They thought they were going to find one. Mm-hmm. In cancer research in general, it's a comment. There's an enormous, maybe more than most other areas of research, but there's an enormous emphasis on finding a target to change. Let's find a target, and one enzyme that affects some cancer pathway. Because if you find the one enzyme or one target, then you can make a molecule to target that enzyme function, and you can make a new drug. And so in cancer, there's an enormous influence on finding a mechanism, an influential mechanism. And actually what this is sort of suggesting is that from a holistic point of view, all of these systems are interrelated and working together in quite a profound way. And when you change your diet holistically, not by a supplement, but by changing all of your food to a new dietary pattern, you change your diet holistically and you change all of these systems then operating together and influencing each other's system to sort of move the whole body rather than isolating one target, which is not the way nutrition works.
Right. What does your father think of this?
Oh, he's excited. I mean, he's very excited to see the results and see the progress so far. To really get this the big time, we need to do another study. We need to do a longer, bigger study. So there's a lot of limitations in this little study, but it's very, very exciting. I mean, the promise here is enormous, and there's a lot of women diagnosed with breast cancer, and one of the more common concerns they have is what should I eat? Mm-hmm. Particularly given the fact that you hear maybe this extra weight has something to do with my risk of getting this, and now I have it, mm-hmm. and now I'm going to have treatment, and now I'm gaining more weight. So nutrition is really a matter of great interest, and it's a very patient-oriented concern. Mm-hmm. It's not as much a concern for research and unfortunately in providers. The medical system, it's not as much, but for patients, man, I wish we could answer this question. We need to answer this question. Can you change your diet and have a material impact?
Well, it looks like you've got us pointed in the right direction.
Yeah, I mean these studies kind of point in an interesting direction.
Yeah. I just want to tell our audience, if you want to hear Dr. Campbell talk some more, he's going to be on, is it a podcast with Dr. Hollie that's coming out?
It is, yeah, it's a podcast. So the Center for Nutrition Studies, they do, I don't know if it's monthly or every other month, I don't know, but he does an interview podcast. So we'll be talking some of these same things probably, but talking coming up soon next month, I believe. Yeah.
Well, I'll put that information in the show more section too. So, well, there's no doubt that you're a physician and you're a researcher and you're an educator and by the way, I was really disappointed when I was reading these two books that you've co-authored and authored. I just did not have enough Post-its to mark all the important stuff. I think you want to put that in the books to help us out. But, you know, there's also, that'll be in the show notes too. And then also the book that you talked about, the history of nutrition, will be another one that people might want to take a look at as well.
Yeah,
So,
the future of nutrition. My dad wrote. Yep. Yep.
yeah.
Which is a lot about the history. So
Yeah, that's why I got confused.
yeah, yeah.
Oh, so thank you so much for sharing this information, and we can't wait to share it with people that are in that situation of being faced with such a terminal illness as cancer and such an awful chronic disease as diabetes. So we do appreciate it.